Good afternoon. My name is Tobias Mattei. I'm the deputy editor of the North American Spine Society Journal, and I welcome Dr. Bess here for the first podcast of NASSJ, and we'll be discussing his article published in the December edition of NASSJ entitled Opioid Use Prior to Surgery is Associated with Worse Preoperative and Postoperative Patient Reported Quality of Life and Decreased Surgical Cost Effectiveness for Symptomatic Adult Spinal Deformity, a matched cohort analysis. Thank you very much for your time, Dr. Bess. And would you like to introduce yourself, your practice location, your fields of interest, maybe some of your previous research, a word or two about the International Spine Study Group who did this paper?
Sure, Tobias. I'm Shay Bess. I'm a spine surgeon here in Denver, Colorado, focusing primarily on spine deformity and revision spine. I'm also the president and the founder of the International Spine Study Group, which is a multi-center study group that is based here in Denver, Colorado. We're a non-for-profit foundation. We formed our 501c in 2010 and have been publishing actually from since 2009 up until now. We currently have approximately 22 sites across the country involved in our multi-center research. The research surrounds all prospective observational studies with a priori-based hypotheses, and so what that means that they're not registry-based studies. They're actually true prospective observational studies, which gives us between level 2 and level 3 evidence for all the work that we do. So this study actually came out of the NASSJ, pulling from a large database that we have from the prospective study of about 1,500 patients.
Would you like to introduce, I know this study was based on the Adult Spinal Deformity Outcomes Database Registry. So would you like to tell us more about this registry and what previous work you've done with it, and then some of we'll discuss later your methodology for this paper?
Yeah, sure. Yeah, the study actually it isn't actually a registry-based study. So this is based on a prospective observational study for which we've enrolled approximately 1,500 patients in the entirety of it. So it's not really the ADO registry, much more, again, a prospective study that we took on looking at the treatment outcomes for operative versus non-operative treatment. Like I said, we've enrolled about 1,500 patients into this data cohort and have approximately 300 publications based upon this very large prospective observation study over, again, about 20 sites across the country. Much of it obviously involving surgical and treatment outcomes, but also research surrounding complications, as well as best practice guidelines, as well as correlations with spine deformity measures and alignment and associated spine deformity. And then more recently, using this data, we've engaged in more predictive analytic type research, forming a basis for development of algorithms for assessment for outcomes for patients, again, with adult spine deformity.
Would you like to tell us a little bit about the inclusion, exclusion criteria and the primary, secondary outcomes?
Yeah, sure. So you bet. So for this study, the inclusion criteria, I should say for the database and for the study, it's going to be scoliosis greater than 20 degrees, and then SVA greater than 5, and then thoracic kyphosis greater than 60 degrees. We established this in 2009. And then particularly for this study, because we wanted to eliminate confounding factors in terms of opioid use, patients also had to have minimum 2-year follow-up, but then also have no prior history of spine surgery. And so I think it would be difficult to compare a cohort of patients that have had either no prior surgery versus patients that have had, say, 5 or 7 prior spine surgeries. So we did our best to emulate a patient that has had no prior surgery, right? And compare those that have had then been treated with opioids preoperatively versus not treated with opioids. There's some questions, okay, why did we use and how did we use the propensity score matched analysis? The PSM that we used in this study, and to back up a little more, the idea of a PSM statistically is to try to emulate a randomized controlled trial. However, you may have a data set like this one that is an observational data set. So what the PSM then does is it identifies, or you identify a priori confounding variables, then to try to emulate essentially the same patient based upon either treatment or prior treatment. So in this scenario, theoretically the same patient, however, one that had been treated with opioids prior to surgery and the other that had not been treated. And then the variables that we used to control that we entered into the PSM was the deformity magnitude preoperatively from an SVA standpoint, scoliosis standpoint, but then also looked at variables that were risk factors for prolonged postoperative opioid use. And that was by Brummett et al. From a prior publication. Again, work that those authors had done, including age, gender, BMI, history of depression, history of drug and alcohol abuse, namely as risk factors for prolonged opioid abuse. And then we control for those factors as well. We also then controlled for the type of surgeries performed, because you wouldn't want to look at then outcomes for a smaller level surgery or a surgery that had fewer osteotomies compared to a larger surgery with several osteotomies. So then we also controlled for the upper and lower fusion levels, as well as performance of a 3-column osteotomy.
So regarding the methodology and especially focusing on the analgesic use, I see that it was basically based on a questionnaire with the following options. First was no narcotic use, then no narcotics weekly or less, no narcotics daily, narcotic weeklies or less, and then narcotics daily. And I see that the opioid users were basically group 4 and 5, which basically were all the patients who were using opioids regardless of the dose. So tell me a little bit of what are the limitations you see with that, and I understand it's a significant challenge to gather like morphine meal equivalents and then use the standard thresholds of 50 or 90. But how do you see the fact that basically we're comparing opioids and without that specific granularity regarding the dosage?
Sure. So in this paper, we looked at daily users versus users, but non-daily users versus non-users. And so clearly one of the limitations for this is that we don't have the MMEs for the patients, the morphine milligram equivalents. Based upon this paper, we've engaged now into another prospective study looking at higher granularity for these patients. And one of those data points is MMEs as well as duration of opioid use. It's difficult if you look at the data points for this prospective study that this was pulled from, which was our prospective operative versus non-operative treatment study. We had about 2,500 data points per patient, which is a fair amount of data collection to get not only from a patient, but also for the sites. The next iteration of this study, based upon what we had learned from the prior study that I alluded to, the prospective operative versus non-operative, the study is called the Complex Adult Spine Deformity Surgery Study. This has almost 5,000 data points per patient. And so there's always going to be this, I think, this balance between what your wish list is for data, comparing that then to what you can actually collect, because at some point, the patients are going to have questionnaire fatigue, and at some point, the study coordinators are going to have work and questionnaire fatigue. So it's always a balance. So I think in summary, the MME portion in this, the morphine milligram equivalents, not having it clearly limitations to the study that we are trying to rectify going forward.
And regarding table 1, which are the variables in your propensity score match analysis, I noticed that the two values that had a very low p-value, much below the level of statistical significance, were the postoperative SVA in millimeters, of course, and then the postoperative kyphosis. So that tells me that, for example, the opioid group, the mean SVA was 38, which is clearly suboptimal, while the non-opioid use was 16. The same thing with the postoperative kyphosis, even though the postoperative kyphosis, I mean, the difference was 60 degrees to 56, so it doesn't seem to be clinically meaningful. But at least to me, it raises the questions whether, I mean, those patients are taking opioids because they had a suboptimal correction of their sagittal imbalance, or
I'd be careful with that statement, because I think that what we know, you need to put it in context. So even though it describes the p-value of the SVA and the opioid group is 38 versus the non-opioid group of 16, I guess it begs the question, number one, is 38 millimeters positive, is that a suboptimal SVA? And so we know that's not the case. It is an optimal SVA, probably for all comers, right? But you have to then also look at the age for these patients. So if the mean age was 62.7 years in the opioid cohort, and then we in the NASSJ also published a paper that looked at age-adjusted alignment, because we know that age or increased age is a kyphosing process. Namely, as you age, you become much more hunched forward, and it's associated with more sagittal malalignment. And so I'm looking at my trusty age group chart up above here, and it says that for the age group of 65 to 74 is about 54.5. For the age group 55 to 64, it's about 30, 32. And so these patients are falling right square in what we know to be roughly anatomic SVA for patients, not only in general, but especially patients of these age cohorts. So I think that happens sometimes when you just look at p-values. A p-value itself won't provide the clinical context for it. And so in this scenario, although statistically they may be different, again, the actual mean value for the cohort are both within acceptable ranges. And then if you look at the range between the two, there are going to be some that were postoperative, maybe malaligned, but probably more patients that had junctional failure, leading to an increase in SVA.
No, I agree with you. I mean, it would be fair to say that, I mean, one group is 3.8 centimeters, the other group is 1.6 centimeters. I mean, it's well below the usual 5 or 7 threshold. And you mentioned, I mean, there is actually some with 7 centimeters, but I agree with you. I don't think this has any clinical significance that would impact the comparison between both groups. So thanks for pointing us that. And would you were there any surprise in the results you obtained regarding when you first designed the study and some of the analyzed variables, and then what you found, and we can discuss some of the findings of the study?
Yeah, so there were several things that surprised us. I was surprised at how much more disabled these patients were preoperatively, despite then having the same demographics, the same deformity. And then we know that operatively that the patients that are on opiates tend to have a longer hospital stay and maybe would incur some delirium in the hospital. But the fact that even though they had somewhat similar, I would say, corrections in the same surgery, how much more disabled they remained, but also how long they stayed on opiates. And so oftentimes patients will tell us they want to have surgery because they want to get off the opiates. And what we're finding here is that if you do the surgery, you think it's going to get them off of it, it may not work. Because if you look at the 3-year continued use for these patients, it was about 45% in the opioid group compared to the non-group. And that's telling us you can't just do the surgery and expect them to get off it. You probably have to do something else. So not only, it's hard to say that it was the causation, right? But clearly was associated with not only worse baseline proms, but I think that the continued disability reported by that cohort, I find problematic, but also the continued opioid use, which clearly is problematic. And I think that this probably speaks to, the hyperalgesia these patients report. I mean, that's an established phenomenon. The more pain meds you take, the more pain you're going to be in. And so that's been repeatedly reported. And quite honestly, I think this is a demonstration of it.
And some people may suggest that, because patients are in opioids, we may not indicate surgery with the same thresholds for the deformity. But what I take from figure 2, just looking, for example, at the ODI, is that those patients, comparing pre-op to post-operative values, those patients, even the patients in opioid, they have a meaningful improvement. The only difference is that, for example, they go from 50 to 36, and the non-opioid already started with 32 and then go to 19. So, I mean, the fact is that even post-operative, the opioid group is still more disabled than the non-opioid. But clearly, there's a difference between pre and post, suggesting that surgery was beneficial in those patients.
Yeah, I think it can help them, but then you almost wonder, based upon that figure, if you theoretically now, based upon the PSM, because that's what it was intended to emulate, right? If you take that patient that has the same demographics, the same risk factors, the same deformity, and receives the same surgery, what happens if you eliminate then the opioids preoperatively? You put them through an interventional program that gets them off the opiates, then do they not only have that improvement, right? But then is their residual disability then markedly less? Because even though the opioids went from 50 to 32 from an ODI standpoint, they still meet threshold then for disability. So they're still considered, from a societal prom standpoint, disabled, right? And so again, you can't ascribe causation, but there is some strong associated value there to say, wow, could we really help these patients more?
And one finding that I found very interesting was the fact that the opioid group had a higher ICU stay, which was, 41 versus 21 hours, and also longer hospital stay, not that greater, like 10.6 in comparison with 8 days. But especially the ICU stay, do you think this is related to the challenge of managing these patients perioperatively, and then those patients are on heavy narcotics, sedated, they may not be easily extubated?
Correct, no question. It had to do with likely terrible pain postoperatively, because they're totally desensitized, right? And then number 2, delirium. And so those hours and those days add up over time, which probably not only is reflected in the cost per quality difference between the 2 groups, right? And so that reflects clearly a societal impact on what the economics of this are. And so I think we all see that. If we have patients that come in with long history of high opioid use and high preoperative MMEs, we know those patients are going to be a struggle, not only with postoperative pain management, but high risk for delirium that usually lasts about 2 to 3 days, which oftentimes is going to necessitate a prolonged ICU stay.
And one point to highlight regarding the cost effectiveness analysis is that when you evaluate the opioid versus non-opioid use, there was clearly a difference. I think it was the cost per quality was $150,000 for the opioid group and $107,000 for the non-opioid group.
Yeah.
But at the same, would you comment on how meaningful that difference is? And my point is that I think the study clearly highlights that there may be several opportunities for us to intervene, as you mentioned, with the preoperative opioid management and standard protocols. But at the same time, I don't think the values in terms of the cost effectiveness would justify insurance, for example, to deny surgery for patients that are on opioids. The same way that we see in our routine practice that, I mean, if you have a patient on a smoker, the surgery is almost automatically denied, and there's clearly worse outcomes. But it's my impression that based on these values, it still seems cost effective, or at least comparable. I don't know what are your thoughts on that?
Yeah, Tobias, that's an excellent point. I totally agree with you. So I think number one, it's still cost effective, especially if you look at the last follow-up cost for quality. It's about $44,500, right? That's pretty good for a cost per quality, right? And so the durability over time continues to improve because the qualities improve and the costs then will go down. But it does represent an ideal target then for us to improve what is probably perceived as a societal cost as well as a healthcare system cost. And people would say, well, so you get them off opiates, well, so what? So maybe they improve on an outcome measure, which is a little esoteric and only used by researchers. What else is the motivation? Well, it's like, gosh, maybe about $50,000 at the first year and $10,000 at the second year, or at the last follow-up. And you say, well, that's a fair amount of money. But as you start layering in hundreds or thousands of patients, that really adds up. And so I think that, again, I agree with you that these shouldn't be used to deny care. It probably should be used to justify the insurance companies providing funding so that these patients can effectively get off the opiates. I mean, you can't just cut them off cold turkey, right? They need to have some help. And I think this justifies the insurance companies and healthcare systems providing help for these patients, especially in this cost effectiveness analysis.
And another finding that was pretty surprising to me, and I think, I mean, if we survey like 100 spine surgeons and we ask them, based on your population, if the patient is taking Norco once or twice a day, do you expect that your surgery after having perfectly corrected the sagittal and coronal imbalance, will those patients be off narcotics? I don't think many spine surgeons would expect that 40% of the patients on opioid would continue on opioid after a year.
Yeah.
So to me, that's very surprising, and it highlights the fact that you see a patient on opioid, and of course, I mean, there's no MME value here, and we could, based just on our experience, expect that the higher dose would be associated with more challenge. But this makes me feel that the appropriate measure here would be to keep the pain management on board for any patient who's taking opioid, because we as spine surgeons, I mean, we treat the patients perioperatively, and sometimes for the deformity, I continue manage narcotics up to a month, but I don't want to be managing those for a whole year, especially, in this challenging patient population. And after sometimes even pain management may be able to even, add other medications, Cymbalta or Lyrica, or readjust, but it's an ongoing problem that you're definitely helping them, you're correcting their deformities, but at least to me it was pretty surprising.
Yeah, I mean, gosh, I mean, at 1 year, right, the opioid, half the opioid group is still using 50%, and about 18% of the non-opioid users preoperatively are still using. But then you get out to about 3.5 years, which is about our mean range follow-up, and about 40% of those that were using opioids were still using, right? And so that's a challenge. So it's not in your practice that at 1 year you're still going to be prescribing. At 3.5 years, you're still going to be prescribing in theory. So something, I think, has got to give in this scenario where we can intervene. So I think that through this analysis, we've shown on several fronts that further investigation at minimum is warranted, but you need to intervene in these patients. We've shown on an outcome standpoint, we've shown on a cost standpoint, and then we've shown also on a continued opioid use standpoint as 3 different metrics that, man, it's worth getting them down or off the opioids, because it's gonna be a problem and a barrier to achieving ideal outcomes for these patients.
For sure. And I know this is a little bit of a tricky question. And first, let me congratulate you on this study. I had the pleasure of reviewing up front, and it's a very well-performed study. But what are some of the limitations you think should be highlighted that maybe future studies could overcome, and what would be the strategy? Of course, we always think about prospective randomized trials, but I think the propensity score matching does a great job in terms of kind of balancing the groups to enable the prospective observational study and some meaningful conclusions. But what do you see? I would say, I mean, looking at the future in terms of evaluating the outcomes of patients on opioids in deformity surgery, what do you see are some future studies that could be designed and could provide some answers? You already mentioned about the morphine meal equivalent, but any other thing you see that could be thought for a future study?
Yeah, Tobias, that's a great question, and thanks for your kind words. We really appreciate you. I think that beyond just MMEs and the duration of use, I think clearly the ability then what the interventions then look like ahead of time to get patients off of opiates. I think everybody kind of pulls out initially as a knee-jerk response to do it needs to be a prospective randomized trial, but we know that prospective randomized trials are extremely expensive, and it's hard to get really high numbers and reach what your power analysis is. And I think the other piece about randomized RCTs is that the patients oftentimes either won't sign up or they don't adhere to it. And so while I think RCTs work well on the pharma side, and I realized the level of evidence was built around pharma RCTs, on the surgical side, it might not be really as relevant and or possible. And so I think building in methodologies to collect data prospectively, albeit observationally, will allow us to answer these questions more. Again, not only the MMEs and the duration of use, but how we get them off and what the rates of recidivism are and how these then impact outcomes. So there's a lot of room, I think, for us to improve on this. It just sets a foundation because we wanted to call people's attention to this phenomenon that is tremendously impactful, namely preoperative opioid use.
And to be honest, I think it's a different focus. I mean, your study, you're trying to evaluate first, what is there any difference in the preoperative disability and patient-reported outcomes between the groups, and then comparing postoperatively? I mean, I cannot imagine a prospective randomized trial that you're going to randomize certain patients to one dose of opioid use, a different dose, and then so what are you evaluating? You know, it doesn't make sense. I mean, we don't prescribe opioid based on our randomization. We prescribe patient on the patient needs, and the great challenge is to really evaluate, as pain is subjective, what are the patient needs and what is proportional in terms of the magnitude of the surgery we are doing. So I completely agree that, I mean, collecting data prospectively, it's another level of sophistication when comparing with studies, just retrospective studies. But the same way that some people say that probably STASKIS is the best study for quite a while in terms of timing for spinal cord injury. I believe I see a lot of limitations in terms of how design things differently to evaluate the question of the opioid, the relationship between opioid and disability.
Yeah, and but if imagine applying to the NIH for an RCT on opioid use, knowing the damaging effects that we are cognizant of based upon the litany of research on opioids in general, to say that we're going to randomize somebody to opioids and make them take it versus not. I mean, there's no way that would get past an ethics and compliance company or board. You know what I mean? So there's all of these, I think, ethical issues that come up on an RCT. It probably, just as you've just said, involves us and necessitates us to design good, high quality observational studies that gives, I think, very good forethought to the fixed data fields that we collect.
Any specific takeaway of this study that you would like to highlight to our listeners? I think you already mentioned how important it is in terms of devising future strategies for prevention and in terms of reducing the preoperative opioid use, but anything else you would like to highlight?
Yeah, I mean, the real thing that we wanted to do with this study is get it on people's radar, right? To show not only the surgeons, but nurse practitioners and pain management folks that this is a real problem that impacts multiple dimensions for these patients. I think going forward, we can refine to say, okay, now based on these data, what should we do about it, and to form more delineated cohorts for it. But again, we were just trying to set the bar and get this on people's radar for their attention.
And in terms of, I mean, if you look at the literature, there's been an exponential rise in the number as well as quality of studies correlating opioids with poor long-term outcomes in a myriad of spine surgeries, from simple ACDF to deformity to fusion, no-fusion cervical lumbar. So I definitely think that it's something especially with the concerns with the opioid epidemic. And to be honest, in most states, here in Missouri, the rule is that you can prescribe opioids up to 4 weeks, and you can extend that to 6 weeks perioperatively. But as a surgeon, I cannot even extend my treatment much longer than that. And that's one of the reasons I always have pain management on board. Even perioperative, I don't know if you've been using, but I've been using like epidural catheters for my deformity and to try to reduce the use of PCA. And one of the things, for example, I mean, if you see a patient on a dilaudid PCA, you're in trouble, because at the long term, I mean, it's associated, we know that it's associated with that specific high that it gives the patient, and usually they may come a month or 2 or 6 months later saying that only dilaudid works for their pain, and when the radiographs are fine and there's no meaningful structural evidence of any etiology that may be justifying what they're describing as a decline in the pain status.
Sure, and again, hopefully this acts as a spark for future high quality research, not only for us as the ISSG, but for other investigators as well, and can be used as a reference then for higher quality research grants and future grants as well.
Perfect. Any future studies of the ISSG that you would like our listeners to be aware and should be checking in the near future? I know it's a very prolific group.
Yes, all of them. I appreciate you saying that. Thanks so much. I think, we've been blessed by being able to work together and have a very high quality data set. Much of our initial work came out of alignment, and the data that we provided the surgical and research community has formed a benchmark for how patients should be aligned. I think going forward, a lot of what we're going to be looking at now with this next round of studies that we have coming out is going to be looking at the spectrum from resiliency to frailty in patients, doing effective risk profiling for patients, and really identifying procedures that are most appropriate for patients based upon the patient's demographic and frailty profile. I think that also looking at probably a better way to capture outcomes, right? So all of our studies going forward are using the PROMIS CAT, and so which is in line with the NIH recommendations. And so can we dial in on where deficits exist specifically in pain and physical function, and how complications may impact those deficits specifically, or how alignment improvements and other aspects of the patient can then tie into the patient's outcomes.
And when I see the most authors from this paper and from all the ISSG group studies are from very well-known institutions, and tertiary care centers. So do you have any concerns regarding the possible, regarding generalizing those findings to, for example, spine surgeries performed at community hospital, either because the complexity of the complexity of the patient is different, or even the population might be different? Or do you think you can use this data without much concern from where it was obtained, meaning from high volume academic institutions and well-known and qualified spine surgeons?
That's an excellent question. And the big thing that we have tried to do in the ISSG for all of our studies is not make it a repository of exotic deformities, right? Because then you only speak to the few that are doing those cases. But if you look in terms of our inclusion criteria, even for this study, right? Scoliosis greater than 20, SVA greater than 5, kyphosis greater than 60. I mean, man, those aren't very rigid, exotic deformities. Granted, there's going to be some on the far end, but there's going to be some that meet that inclusion criteria just barely. And we did that intentionally to try to speak to all listeners. I think that we as surgeons in the ISSG clearly are evolving, probably real time, based upon what we learned from our studies. But that's really the reason why we do this research. I mean, we're all in this for benefit together. I mean, we're in the business of researchers to try to change behavior for the better. And hopefully, as we as researchers in the ISSG are improving our behavior, hopefully by writing manuscripts and publishing and presenting on the podium, we're hopefully influencing other surgeons as well to listen and hopefully positively impact their behavior and practice as well.
Yeah, and I completely agree that, I mean, when we're thinking about interventions, we first need to better understand our problems, right? So, I mean, the case of deformity, some surgeons may look, especially with patients with major sagittal imbalance, and think, oh, it's normal for them to be on opioids because it's such a bad deformity. But your study highlights that this is, even though we may be normal, it shouldn't be that way, and we need to be proactive in terms of devising those preoperative pathways to get those patients out of the opioids, so that our intervention at the long term may reach better clinical outcomes. So I thank you very much for this study, and it does help us understand better the scenario we are in, so that we can devise future strategies to improve our outcomes.
Well, thanks, Tobias. I really appreciate it. I appreciate you taking the time to read through, and then for this interview. It's an absolute pleasure.
Okay, perfect. In the name of the NASSJ and our listeners, we thank you for your time. We know you have a very busy schedule, and we look forward to see other future studies from your group.
Thank you so much. We in the ISSG thank all of you. So thank you very, very much.
Perfect.